It's my pleasure to introduce our next speaker. That is, again, Chris's associate, Dr. Anirejuoritse Bafor. Anir is an international scholar and a research scientist with Dr. Jobst at the National Children's Hospital in Columbus, Ohio. Anir was the former head of orthopedics at the University of Benin in Nigeria, so he's sort of seen both sides of the world, if you will. He was also the LLRS traveling fellow a few years ago. So Anir is going to talk to us about establishing a limb reconstruction practice in an austere environment.
Okay, cool. So I'm going to be discussing limb reconstruction in a resource-challenged environment. These are my disclosures, and just to emphasize, I'll be discussing the off-label use of procedures, equipment, and implants. So this will be the outline. I'm going to talk about this subject from a resources perspective, location, logistics, and then I'll end up with a brief talk on education and research in this this environment. So just to start off, to emphasize that staffing is probably one of the biggest issues, as highlighted in this 2015 publication by Spiegel et al., where it really emphasizes the problems with low volumes of staff in low and lower middle income countries. And so in addressing the unique peculiarities of practice in a resource-poor environment, we kind of have to think about it from an innovative perspective and utilize some outside-the-box thinking. So regarding staffing, I mean, the surgeon who's the key resource person here has to, like Dr. Yop said, wear many hats. So he's going to function as a surgeon, probably going to function as the firefighter, the nurse or the nurse practitioner, as the physical therapist. And he must also be prepared to take on several identities. He's going to be the man Friday in some instances, working behind the scenes to ensure complete supply of inventory, both equipment and implants. And so I'll just go on to some of the local solutions that we've tried. I'm going to use limb assessment as an example. So just like Dr. Manga Pareha pointed out, the 51-inch film is not usually available. So we've tried things like using a CT scanogram. Of course, the problem with the CT scanogram is patient positioning is always a problem. You can't always account for rotation. And also important is that the images are obtained with the patient supine. So you lose the benefit of weight bearing. Stitched HKA films, there is a learning curve involved with that, as we found out with these images. And sometimes you get these really horrible images and you can't really make a whole lot from these. However, like I said, there's a learning curve, and with practice, you train your radiographers to get it right. Intraoperatively, some of the solutions have been to convert non-medical grade power tools to to things that you can use intraoperatively. This is a typical example where you use sterilizable drill covers and coupling attachments. And so you can take a regular power tool from a hardware store and convert that to something that can be used to power instruments within the theater. Technique modifications and hardware alternatives I'll take in the following screen. So this is an example of technique modification where you can use the acute deformity correction technique to address angular deformities of the knee. The problem with this, of course, is whatever correction you get intraoperatively is probably all you're going to get, and you lose the benefit of being able to make adjustments post-operatively as would be the case if you were using, say, a hexapod or something like that. There are also problems with soft tissue issues intraoperatively. But with adequate planning, a lot of these problems can be attenuated. Another problem is when you have severe deformities. So you can use the acute and gradual correction. And essentially what you're doing here is you are taking a severe deformity and making this into a mild deformity. And then you can then apply a hexapod and achieve complete correction postoperatively. The advantage of this is it eliminates the need for strut changes, which comes in really handy when you have limited inventory. This is an example where we are taking commonly available hardware and using this to, so a cancellous screw with washers and then steel wires, and you can use this to build a flexible construct to achieve growth modulation in cases where you don't have the right implants, and it works. So handling location logistics is also a big problem. You need inventory, you need equipment, and establishing links with contacts in high resource centers has been a huge resource. You get a lot of donated equipment and implants. And just to say also that usually because of staffing problems, a deformity correction service as a standalone is usually not possible. And so you should be prepared to entertain the option of having this embedded within a larger clinic setting. With some ingenuity, you may be able to modify this. So for example, you could have a 1-hour club foot clinic hold before your main clinic or something like that. And then the other thing is location also is a problem. Patients, because of non-availability of this service in a, commonly you have patients needing to travel long distances, sometimes over roads that are not very good. So it's almost impossible to have patients, for example, coming in for weekly follow-ups after having limb deformity surgery. An alternative is leveraging on social media like WhatsApp as a telemedicine tool, where you get X-rays and then you can discuss with the patients after reviewing X-rays on WhatsApp and either adjust treatment or something like that. Collaborations are absolutely important in maintaining practice in these peculiar environments. As I said earlier on, there's a huge dependence on implants and equipment donated from contacts in high resource settings. Education and training is absolutely valuable. And this, in the absence of proper fellowships in these areas, informal fellowships in high resource centers, attendance at training courses have proved to be a very useful educational resource. We also have the concept of the reverse fellowships, where faculty from the high resource centers in the West, they come down to these to the resource challenged environments and offer training at these centers. The problem with this is usually this occurs over a couple of days to a few weeks. However, a little is always better than nothing. And I think I'll just end up with a little note on research. Research is also important because it offers the unique perspective from the low-income centers and the lower middle-income centers. This enables a global perspective on the disease burden where you are able to see the entire spectrum of disease. And so multi-center research collaborations, as much as is possible, should be encouraged. So I'll just conclude by saying that working in a resource poor environment poses its own unique problems. However, with a bit of ingenuity and creative thinking, a lot of these problems can be overcome. Thank you.